Welcome, everybody. Thank you for joining us. And I just want to start by saying that my favorite piece of information, courtesy of Frida, acquired as I prepared for this panel, was learning that most lab mice are male. Today, we had coffee before the panel, and I learned that most lab rats are also male. So I cannot say I was surprised. None of you were surprised. But one thing I want to accomplish in this panel is for us to all learn why that matters. And maybe we can start a mouse parody movement. And rats. Let me just introduce everybody really quickly so you know who's speaking. They're not matching. OK, let me do it right. We've got, and you know their bios. I'm just going to give you the names and quick introductions. Here we've got Frida Lewis Hall, Executive Vice President and Chief Medical Officer of Pfizer. Sarah Lynn Mark, Founder and President of iGiant, the first Senior Medical Advisor to the Office of Women's Health, and an expert on women in space, which we're also going to talk about, the physiology of gender in space. We'll talk about that briefly. Paula Schneider, President and CEO of the Susan G. Komen Foundation. Janine Austin Clayton, Director of the Office of Research on Women's Health at NIH, and Isabella Donnell, Deputy Director of the Pan American Health Organization. So we also have a global voice here. They're a really disparate group. They're really different voices and different experiences. And I moderate a lot, but I had to really think hard about how to make this group a coherent conversation. And I want us all to be able to leave here in an hour and say, wow. Obviously, we are going to talk about things like women's underrepresentation in clinical trials. 20 or 30 years after we supposedly solved that, it's still a problem. I want to talk about why we haven't really fixed it, what's beginning to get better, and why it's important. We want to talk a little bit about women's role in the healthcare system. We are the caregivers, both as family members and as the professional paid workforce, underpaid workforce caregivers. We are the patients. We are responsible for 57% of a doctor's office expenses, if the figure Milken gave me is correct. We are the decision makers in our families, but we are not the decision makers in the system. We are not the power brokers in healthcare. Women up here, some of them are. I want you to just raise your hand if you've not been listened to. You're all sophisticated. You're all empowered women, right? If you've gone into a doctor's office and you just couldn't be heard. Guys, me, right? It's all in your head, right? It's stress, right? I mean, not that we don't have stress. And raise your hand if you think that happens to the men in your life who are important to you as often as it happens to you and your sisters and daughters. OK, we have a consensus. So I began to think about healthcare and the larger moment going on behind us or outside and everywhere, right? We're not here to talk about Me Too in the sense of sexual assault. We're not here to talk about Harvey Weinstein. But I began to think about the ways in women in general, how we've been activated, and how people are ready for change across many aspects of our world. And what does that mean for healthcare? What is the unfinished agenda for women in healthcare? How do we identify that agenda? How do we lead our way out of it? I also want all the women here to talk a little bit about how they became leaders, because I think that's just a really important thing for other women to hear. And as we started talking, we met for half an hour before this. We came up with a long list of other things. So if we have time, I'd really like to talk a little bit about health tech and women, because we all came to a rapid consensus about that. As I mentioned, if we talk a little bit about space, because it's fascinating, and it is part of the research agenda that'll be more important in the future. But I wanted to start by getting everybody in the conversation. And as we talk, we could spend 5 weeks here talking about what is women's health. But I want each of the panelists to just say one thing that they want to make sure that they think of when they hear women's health, or they want to make sure is part of that agenda. So just quickly, it will not be an encyclopedic. It will just be a conversation starter. Janine.
So great. I think of women's health as everything that affects a woman from head to toe. And the way that I translate that thinking into the way I speak is I refer to it as the health of women. Everything that affects the health of women is women's health to me.
Isabel.
Well, PAHO is the regional office for WHO for the Americas. So I'm going to start with the WHO definition of health, which is a complete state of physical, mental, and social well-being and not just the absence of disease. And when we apply that to women, we know that there are many factors that prevent them from achieving that state of well-being that we really want. They include power relationships between men and women, social norms that prevent women from getting the jobs, opportunities that they need, violence against women, et cetera. And I just want to add to the picture the feminization of poverty, which is clearly contributing to issues for many women, and the inequities in health. Globally, the inequities in health are a key issue. We have groups of women that have less access to health, that have social determinants that are issues, gender inequities that are issues, and they include indigenous women, Afro-descendant women, rural women, et cetera. So those are just some key things to throw out.
Put us on the global stage where we belong. Paula.
And that where you live doesn't depict whether you live.
An integrated approach and taking it from a sex-gender component, looking at the biological construct as well as the psychosocial construct, and being very clear that we're moving beyond that bikini medicine model of what we deemed women's health, where we just focused on breast tissue and reproductive. So it's really everything in our lives.
Frida.
So Sarah Lynn and I were just reminded that 20 years ago we were sitting in nearly the same place having, unfortunately, nearly the same conversation. But our definition has changed. So instead of the below the belt definition of women's health, we were trying to move to the whole body. And I think now everyone has described a need to move outside of the body as well in terms of all of the social determinants and to address the inequalities.
And then before we sort of dig into the research agenda or the research realities, I do want to just ask, leadership is really important. It's a theme of Milken. And it's something that came up in our preliminary conversations. And I think it is something that women often struggle with. So each of you really quickly, you're all leaders, something about how you let yourself be that.
I'm actually an ophthalmologist. I am an eye doctor and researcher. And when I became aware that 2/3 of the people that are in the world that are visually impaired or blind are women, including in the United States, 2/3 of the people that are blind are women, and that we couldn't explain why that is. Women do live longer than men do generally, but that in itself does not explain that disparity. The fact that we could not explain that was incredibly disturbing to me. That's actually what made me transition to women's health. So the leadership roles that I've taken have been around championing a cause because something was bothering me, and I almost fell into it because of that.
Isabella.
When I think about how I became, how I got into the position of deputy director at the Pan American Health Authority, I mean, I start with my family, which was really important, the support that I got from my family, the idea from both of my parents that you can do what you want to do, you know, don't shut yourself down. That was important. I think the women's movement, I was a teenager in the 60s and 70s, was in college and med school. Critical to me, that support and women working together to lift themselves up and address the discrimination that we all, I think, perceive at some point in our lives. And I think that support from women, I've worked mostly in women's health, reproductive health. I think we're drawn to that because we're women, or at least back in the day. I think now maybe the space is more open. But certainly in those circles, there's a lot of women, and I think women providing support to one another was key to my getting to where I am. So,
Paula.
Okay, I took a major right turn here to come into healthcare to begin with because my background is in retail and in fashion. And I spent 30 years honing my skills there and was in private equity, buying companies and learning the business of business. And I'm a breast cancer survivor. My mom died of breast cancer. My brother died of prostate metastatic cancer. I have 2 daughters, enough said. So for me, it was all about being able to take something that is my passion and taking my business acumen and combining both of those to run an organization that can really make a difference in the world.
Well, I think following the theme, and that is creating our own opportunities. I was a young girl growing up in Colorado, and I wanted to be a doctor to practice on the moon. Fortunately, my family told me that you can do this, not letting me know that women were not allowed into the space program until 1977. first flight 1983. So for my world, I actually had to create my own opportunities. And when I was in training, I realized women were really getting the short shaft of it. The care was being dissected, as we just talked about earlier. So I created our first women's health fellowship in the US. It was then brought to Washington to try to do it on a national level. And then from there, creating national centers of excellence in women's health. And there was a component for leadership. But what I found was that women were being marginalized. I mean, I kind of look around the room right now, and it's predominantly women, which is wonderful, but where are our male colleagues? Because you can't be a leader just with women. You have to be a leader of all people. So we then created the National Centers of Leadership in Academic Medicine, which were for both men and women. So my mantra is to have individuals promoted because of their abilities, not because of or despite their gender.
And Frida.
So I wanted to be two things. When I was 6, I knew I wanted to be a healer. And I really didn't think I wanted to be a leader. I didn't want to be out in front. I didn't want those things until my mother redefined leadership for me and said simply this: you don't have to lead from above. You can lead as a foundation under people's feet, and you don't have to lead from in front. You can lead as the wind at people's backs. And I loved the definition of being able to lead from where you were, following a passion and a purpose. And so early on, putting that in practice, I had a chance to do all kinds of wonderful things around kind of my vision and purpose. And then it got shaped further for me a little bit later with one of my managers or bosses, a leader in an organization I served in, and he kept saying, I'm a visionary leader, I'm a visionary leader. And after a while I said, actually no, I think you're a hallucinatory leader because you kind of see it and no one else does. And you know, he kind of watching him and working with him taught me the value of kind of shaping a vision, and you don't have to lead, people will follow.
Well, if anyone's tweeting, make sure you get that. Let's talk a little bit about research, because research is actually, it's an area, it's pivotal. If we don't study things, we won't understand them. Women are still not adequately represented. It is better than it was, but nobody up here thinks it's where it needs to be. So anyone who wants to jump in, in 1991, a law was passed saying that, I guess it's federally funded research had to have. How far have we come? And then the 21st Century Cures Act, which was, I guess, 2 years ago, or approximately 2 years ago, I think it was 2016, gave us some more tools and a little more oomph. So let's just, you want to start? Sure.
Absolutely. So now actually over half of the participants of NIH-funded clinical research are women. But that's actually not enough, because even though half of the participants are women, fewer than a third of the phase 3 clinical trials, those big studies, have any disaggregated results for men and women, men and women separately in the publications.
So we're just putting the woman in the study, and then we're not saying what we learned.
Absolutely. So even though women are included, the results are not known. And so that is certainly not maximizing anyone's return on investment. And so we're moving, what we say now is we want to move beyond inclusion to intentional integration of considering sex, being male or female, across the entire biomedical research continuum from the laboratory to the clinic. And so one of the ways that the 21st Century Cures Act has really accelerated that possibility is by requiring applicable clinical trials to have their results reported in a website called clinicaltrials.gov once they are completed. And so we anticipate seeing those results disaggregated by sex, gender, and race ethnicity in the future. So that's gone into effect. However, because the trials, it went into effect trials that started, you heard that was 2016, started last year. In 2017, we're not going to see those results for some time because those trials take several years. So what we'd like to see then is our industry partners in the publishing field make sure, because they have a real gatekeeper role. Journal editors have a role in making sure those results are included in the publications. How did that treatment work in men? How did that treatment work in women? Were there more severe side effects in men or women? Were there differences that are important in terms of dosage for men and women? And of course, across the life course is another variable that we really need to take into consideration.
What about at Pfizer? I mean, you're not NIH funded. You're doing studies in a pharmaceutical company setting, a huge, important company. how have women, as you do a phase 1, 2, or the clinical 3, what's changing? And
Well, the
what are you
same.
doing? Right.
So not just in response to the laws, but in the response to unmet medical need. We've had an effort ongoing around age, gender, and age at both ends of the spectrum, both for children and for aging, and for racial and ethnic differences. So really looking across the spectrum of people and not thinking just about numerically. So half for women is not enough, really thinking about who's affected. So if 2/3 of a population is affected, we really want to match the people for whom the medicine is likely intended and will be used. And so not just getting the numbers right, but also understanding all those underlying things that Janine mentioned. So is there a dosing difference? Are there some fundamental differences in disease presentation? Is there an opportunity to mitigate adverse events and other downstream effects by really understanding the biology of the disease and understanding the host, that would be the us, and putting those two things together to make sure you've really optimized the development of treatments and interventions.
Yeah, so we all wear multiple badges. So from the SPACE badge that I've worn, SPACE is an extraordinary platform to study accelerated aging. Unfortunately for every one of us in this room, we're aging. And what is really exciting about SPACE is that we've developed countermeasures to slow down that process or even to prevent some of the issues that we encounter. SPACE is an amazing platform to study sex and gender differences because the body adapts very quickly in space, very dramatically. So you can discern small differences which have huge, significant impact. And now we can translate to what is happening to our lives on Earth. So there is that terrestrial component. So for NASA, we've been studying these issues since women have been part of the SPACE program. We have a study that was published in 2014. Janine actually served on that study with us, where we looked at every single system in the body. And I highly recommend for you to take a look at this from whatever angle you look at your life, from health, every aspect, from behavioral health to musculoskeletal, reproductive, neurological, cardiovascular, every component. And then from the other badge I wear, which is the founder and president of iGiant, which is an acronym that stands for the Impact of Gender and Sex on Innovation and Novel Technologies. I learned in Washington you always have to have an acronym for something, especially coming from the space agency. And we're basically an accelerator for gendered innovation. So a lot of the research that you've heard about today and will continue to hear about, we accelerate the translation of that research into gender and sex-specific design elements, such as products and programs and policies and protocols across healthcare, IT, transportation, and retail sectors. And we do it so that we improve the safety and quality of life, including work performance for men and women.
So let's talk about breast cancer for a second, because obviously women are going to be involved in breast cancer research, but maybe this is a mouse question. When we study breast cancer drugs, are we using male mice? Does anyone know? And does it matter?
Not always.
Not always. But what are the areas, the larger areas of, I mean, breast cancer is part of a larger effort to understand cancer,
Right.
a larger, the big genomic project, what I think it's called All of Us now, they changed the name. There's a big effort to make sure that reflects the population. So as women are not adequately represented in broader research, what's the fallout for breast cancer?
Well, we're the inequities within the inequities, right? Because if you have women overall that are not getting the health care that they need, and then you have the different populations of women that are underserved, underrepresented, underinsured, African American women, Hispanic women, and again, when it goes back to your zip code, right? It goes back to where you live. That shouldn't define whether you live. And part of our world is, we're trying to decrease deaths by breast cancer, and about half of our work is done in community, and trying to figure out whether it's cultural or whether there's opportunities for us to have better healthcare or patient navigation or whatever it is in each of these communities. We have 11 cities that we're working on in African American initiatives. And it's hard because it's community related, it's one-to-one, it's expensive, and we don't go in there as the great white hope saying, hey, we know exactly how to do this. What we do is we put together thought leaders in the African American community to help us discern what is happening, whether it's cultural and we have to talk to people where they eat, play, pray, or whether it's that they aren't getting enough, help in patient navigation, or or finding quality health care, or having healthcare providers that are reading their mammograms correctly, or their, all the rest of their testing. So there's lots and lots of work to do. The flip side of that is that we're predominantly a women's disease. And then you have men, right? And then men have the stigma of getting breast cancer, and a lot of men don't first of all, don't even think about it if they feel something, or if they feel a lump in their breast, they don't think it's breast cancer. And we, as an organization, have to always make sure that we always talk about men and women, and not just women, because it alienates the men in the group. And so we're sort of the flip side of both of those.
Sure.
So I don't work on research, but I mentioned the issue of inequities in health outcomes. That's a key issue for all of the Americas, including the United States. We have huge inequities in health outcomes, and for women as well. And when we think about that, access to health is certainly a piece of it, but it's sort of the tip of the iceberg. Most of the inequities are related to social determinants and what's going on in your life, what's going on in your community. Racism is clearly having, we think, an impact, for instance, on preterm deliveries. So my plea, as I think of violence, I think is another issue. 1 out of 3 women globally, and I believe this is true in the US as well, I'm not going to ask women to raise their hands, but 1 out of 3 women has experienced physical or sexual violence. And I think we need...
Everyone should just stop and think about that number for a second. 1 out of 3.
But so I think we need to be pushing towards doing research related to social determinants. And yesterday, this was discussed a little bit on the panel. It's not easy. It's not easy. It's not an RCT, a randomized controlled trial. So how do we do that research? I do think that's a key question if we really want to start to close some of the gaps that we're seeing. So I'm just going to...
No, I mean, I think social determinants and equity is a really important issue. And when we think, social determinants has become a big part of the healthcare conversation in the United States, at least over the last couple of years. And it's not just, it seems to be taking root. It seems to be, it's not just the shiny new object that we talk about for 3 months and then move on. It really just seems to be part of how policymakers and researchers are starting to think about things. And I would say this is a bipartisan realization up to a point, a greater awareness. Maybe not the same solutions bipartisan, but I think there's someone who's covered policy a lot. I think there is a greater awareness of how our environment. We do tend to think of them, or the conversations I've been part of, they aren't that gender related. They're poverty related, they're education related, they're homelessness, transportation. What is the woman piece? As we talk about social determinants, where do we have to really be thinking, what is the issue? I mean, one of the issues is obviously that women outlive. There are more women live longer, they end up living alone. You're not going to be able to drive yourself, things like that. But it's broader than that. So when you think of social determinants, what's the woman piece that we all need to think about? Whoever wants to jump in.
It's an important question. And when you look at the healthcare system, and you alluded to it, about 80% of our dollars are spent by women either for their own healthcare or for their families. And often they're the most disadvantaged because from the economic standpoint, it's challenging. A woman may not have the same level of income. She may be dependent on her partner's income, and if she's divorced or widowed, she may lose her access. That's why some of the exchanges are very important for a lot of women in many communities. And when you destabilize these exchanges, you often destabilize their opportunity to get health care. So there has to be that safety net. And I think the other issue that we have to acknowledge is that women's health often has been marginalized and politicized and polarized. And it often alludes to the fact that when you think of women's health, you think of it as reproductive health, and then it has a bow and arrow shot at it. So I think, again, if we can take it more to that integrated approach, hopefully that can neuter some of that stigma that we have talked about in regard to women's health.
Good.
So 2 things. The first thing is we're always saying women live longer. I actually think women just take longer to die. And because those last years, not good for most, right? So, so you decide if that's a good thing. But during that period and before.
Because we're doing a million other things at once. We have
That's
to multitask.
right, we're multitasking
Right.
again. So living and dying at the same time.
It's like that to-do list, right? You didn't get to the one that says die.
But I think the key is during our entire lives, we have very unique things that are happening to us biologically and socially. And medicine tends to be lumpers, not splitters, which means we want to segment everyone into something, and we use a very derivative model. So you use a white male model, and then you say, okay, how are these people different from that model? And then when you take the, how are white women different from white men? Then you say, okay, we got that under control. Now let's see how, this group is different from these groups. And I think if we took a step back and started to do what's been done in medicine at the biologic base, right? So think about cancers. We thought it was one thing, it's not. And we're not even thinking of it derivatively anymore. We're thinking at the cellular level. So if we took a giant step back for women's health and said, none of us up here are the same, what can we understand about each of us that would allow us to have the best health, your definition, right, in all of the dimensions, and then back into the things that we need to do to study and close knowledge gaps, to serve and close clinical gaps in each of those domains. And that's just not how we're doing it. We're kind of going from a standing start and trying to fix all the things that are wrong. And I think what we may need to do around health in general, but maybe using women's health as a platform for that, is take the giant step out, start from scratch, if you would, and build from the base. What would a system look like that was elucidating and applying that knowledge to ensure the best health of everyone that we see?
Yes,
Grandiose, maybe hallucinatory.
But that is what the beauty of it is, that you can shoot for the
gotta start with the
stars
hallucination,
and do
right?
that. And one of the thoughts I had was to create centers for gender and precision health, which actually weaves in many of the concepts that you're talking about. And it's not just genomics. We tend to think precision, we think of genomic medicine, but it's beyond that. And we weave in the research component and the career development component and the community outreach component, as well as the delivery of care. I mean, wouldn't that be incredible to be able to do it? And what's nice is that we've got 20-some years now where we've built the foundation through these various other centers that it wouldn't have a lot of expenditure to move us into that area. And all of us could be engaged in it. So anybody who creates and anyone who's involved in a health system. So that moves us more towards that realm of gender and precision health.
Has the NIH Office of Women's Health broadened, how does it define women's health and how is that expanding?
Right. It's great, very timely. So just yesterday at my advisory council meeting, I announced that we are thinking about women's health as the health of women. And everything that constitutes the health of women is part of that definition. That's a very broad definition.
And how was it
different.
received?
The room was full. It was, Senator Mikulski was there, former Representative Connie Morello was there, NIH leadership was there. It was very well received. So that's moving in a different direction, and some of the comments that Frida made are right along those same lines. The biology or internal factors, the external social contextual factors, all in the context of a woman's life course, was a multi-dimensional framework that we announced yesterday. So that's available on our website. And I think that this weaves back to our earlier discussion about research and why it's so important. Research generates the evidence upon which clinicians make their treatment decisions. Every single one of us deserves to be treated individually, appropriately, and we think that we are in a doctor's office. We think that that recommendation for that antihypertensive is based on your background, your age, your circumstances. And for many, many cases, we just don't have the evidence to make those decisions. And until we can generate that evidence from our mouse model of hypertension or whatever disease we're studying, right, to our translating, putting that evidence into practice, we don't have sex and gender-based evidence to truly deliver individualized care at this time. System-wide approaches are really needed. I don't think it's grandiose because we're not going to fix this with these one-off approaches. Clearly what we've done to date has got us where we are today, and that's really not where we want to be. So we're looking towards transdisciplinary, multi-sector approaches. We've got to find ways for all of us up here and others to be together, converging on a problem. Convergent science is another way to look at it. So I'll give you one quick clinical example. Maternal mortality in this country is rising, where it is decreasing in our peer countries. We are number one compared to our peer countries. That is a very bad number one. You don't want to be number one in maternal mortality, right? We're great. It's greater than Libya, Turkey, and Vietnam in the United States.
It's astonishing
Okay.
that some of the reporting that's come out over the last year. It's
Exactly.
really shocking.
So actually, I was just reading a paper yesterday that said group counseling of new moms was just as effective as one-on-one counseling. That seems to be a lot more cost-effective than the system we have. So we need to be able to put those unique solutions into practice and involve our entire culture in the culture of health, and that's the notion of the culture of health, and move that forward.
Isabel, when you talked to me about the Sustainable Development Goals, SDG, and I went and looked them up. And there were two relevant ones. Gender was a category, and health was a category. The fact that they are part of the sort of international agenda, what does that mean?
So,
Is it a box that's checked, or is it moving forward?
yeah, so, and all of the goals actually are so interrelated. Women's health is so related to gender equality and women's empowerment, and there's another goal on equity in education and economic status. So all of these goals are very, very interrelated. And I do want to say that I think the goals are the culmination of many decades of work by women and men starting with the first conference on women in '75 in Mexico, the ICPD in Cairo, Beijing, et cetera. And now we have gender equality and empowerment of women as a goal that's been agreed to by all the countries of the world at the UNGA.
Hasn't changed his mind on that one? We're still with you.
We're still, as far as I know, they're signatory. We are signatories. So. And so I think what the goals do, because you could say, just a bunch of goals, it's just a bunch of paper, but they do hold governments and people accountable. So for instance, I'm holding this document, which is Gender, Health, and Development in the Americas Basic Indicators. And we are tracking these indicators with governments, with women's organizations, with social organizations who are going to keep governments' feet to the fire. What are we doing? How's it going? And it doesn't just, of course, it includes mortality, access to services, sexual and reproductive health, but also employment, political participation, education, wealth and income inequalities, environmental health, et cetera. So it's a multitude of indicators. They're all interrelated. So, and I think this is one way of keeping us, all of us, accountable to these commitments that we make to women. Can I say one more thing?
Yeah,
Just following up a little bit on what Janine said.
You don't have to ask permission.
Okay, sorry.
We're all empowered.
Well, because as she was talking, I was thinking about the issue of violence, 1 out of 3 women, and the research that has been done on violence, so let me tell you what we found is that violence against children, when children are either exposed to violence, even if they see it, or more so if they are actually violated as children, men become, boys become perpetrators, and women or girls often become the victims of violence. It's a terrible cycle, an intergenerational cycle. So I found this to be very interesting, because the key then is to start with, to a certain extent, I mean, we want to treat women, we have to have services for women, we want to protect them if they've been physically or sexually violated. But if we're going to prevent this, we have to be thinking about children. We have to be thinking about parenting. So this is going way beyond the health sector. How do we help people be better parents? How do we protect children? How do we make sure that educate children is aware, so they're aware, adolescents. So it just opens things up. And it actually connects, we were talking about this also earlier, men's health to women's health. Because if men are the perpetrators of violence, but it's coming from something that's happening to them as children, it's very important for us to be looking at boys' health and men's health. So I just want to kind of throw that into the discussion as well.
We're going to take some audience questions in a few minutes, but before I go there, there was a thing we just sort of started talking about informally this morning, that there's the role of health tech. There's so much talk about big data. We haven't yet learned to use it. I think everybody thinks that at some point we will figure it out. There's a million apps. Some of them are useful, some of them are not. It's hard to know. But there's just like as there's a lack of leadership in the business world and the health industry for women, it's even worse in Silicon Valley, right? There's a real leadership gap in tech and women. So let's talk a little bit about what we're seeing in this absolutely enormous, constantly proliferating data/tech world, and is it 26-year-old guys inventing things for 26-year-old guys, or does it matter for women's health? And also for the patient tools for breast cancer, we should also talk about.
We have this woman, her name is Regina Barzilay, and she's a scholar at MIT. And we are working with her because, and I'm going to get all the medical terms wrong, so do forgive me, but you'll understand the layman's thought. And she's a breast cancer survivor, relatively young woman, and she's using machine learning to read mammograms. And she does this speech. It's really compelling because she shows her mammogram 3 years before she was diagnosed, and how at that point in time that she could diagnose using her machine learning of reading the mammogram, how she could have predicted her cancer at that point because it was evident, but not to the naked eye. So I think there are very specific things. I'm going to come back for just a second because we all have a responsibility here as business leaders, and we can boil the ocean. And we can figure out, there's a million things that we have to work on. And I think for me, it's trying to stay in my lane of doing the best I can and the most I can for equality for women and women's health. But that is the business that I'm in. But it's figuring out all of these steps and keeping women interested in the sciences, which I think is really interesting. I didn't grow up in science. I was a design major, and we do a lot to make sure at Komen we do a lot where we keep our young investigators interested and we sponsor a lot of them because we want them to stay in breast cancer. We mentor, and not only mentor but sponsor young women that are in our organization because we want them to stay in the field. So I think that there's an onus of responsibility as business leaders for us to all figure out what does that mean for us, whether it is breaking the chain of violence or whether it is, figuring out what space is going to tell us. But I think that the onus really leans on the leaders of industry to do that. And I think that's a really important point for all of us to consider, because if you're here, you're leading something.
Frida?
There are a couple of things that I'm really excited about. First of all, anybody who knows me knows I can't even use my phone, except to make a call. And beyond that, it's all beyond me. But I think.
Do you know any 12-year-olds?
Yeah, I actually have a soon-to-be 5-year-old grandson that works my phone beautifully, as it turns out. So I have more Power Ranger downloads than I'd like to think about. But that having been said, I do think that there are two areas that I'm really excited about for tech. The first is on insight generation. For us, if you think about all the data that likely exists from all the places it could exist from, and what we could then understand about the biology and the behavior of women wherever they are and whatever they do. If we were able to tap into that reasonably, which I think we could, right, if we were focused, then we would be starting at a very different base than we are now. So I think insight generation, both using the data we already have and also accumulating data that we don't yet have that we believe that we need, would transform this space in an unbelievable way. But I also think application will as well. New diagnostics, you gave a great example with the technology that you mentioned about reading mammograms, but also other further reaching technologies and also other applications for women. I've been in Ethiopia where women literally walk for a day and a half to 2 days in order to get their children vaccinated. Why? Because there's no refrigeration to get the vaccines to them. Really? So if you think about it, we probably have technology in hand already or could target it if what we knew we needed to do was deliver vaccines to women who had children in very distant villages. We could also, by the way, deliver a prescription to Ms. Johnson, who has congestive heart failure and lives about 6 blocks from the CVS or the pharmacy, and because she has congestive heart failure, you can't walk it and back, so she doesn't take her medicine. Can we deliver something to her? Don't we have the technology for that? So I think that if we actually defined some of these issues using the data that's in hand already, both biologic and social determinants, we could problem solve very quickly. And I think that the people who are generating these solutions are doing so because they know the questions they want to answer. If we told them, I feel very confident they would answer our questions.
Well, just following up on questions, one of the goals of the iGiant is to get everyone to see through a sex-gender lens. And often we start our roundtables asking 4 basic questions. Have any of you ever taken a drug or had a device that caused a side effect or known anyone? Have any of you ever had problems using your devices where you've developed carpal tunnel syndrome? For example, we know a lot of physicians, female physicians, have trouble with electronic medical record. It was designed by male engineers, and the way our male and female brains process information is very differently. So it's like that old saying, dancing backwards in high heels, the Ginger Rogers saying, women often get extreme burnout from trying to use a system that doesn't work. We often get carpal tunnel syndrome from trying to use devices that aren't designed for our tactile sensation. Believe it or not, women have greater tactile sensation at their fingertips. Ever have any injuries from wearing shoes, and not just the stilettos? Some of them are not designed for your biomechanics, the way you walk. And then finally, any challenges in your workspace besides just the ambient temperature designed for most men wearing suits and ties and you're freezing, but just even where you're sitting, your ergonomics, your position. And then finally, you probably all know someone who's had a car accident. Did you know women have a 47% chance of more severe injuries in car accidents? Think about when you get into your car, where does your head hit against the headrest? Is it supporting your neck muscles, where women generally have less muscle strength? So when you take it down to that level, you see technology impacts every single aspect of our lives. And the wonderful part is, all my colleagues have said up here, there's something we can do about that by bringing industry together and bringing our agencies and our advocacy community, as well as our academic communities, to really distill, take the deep dive, and think about these issues. And in fact, we're going to do an artificial intelligence summit in San Francisco. You're all invited November 8th to take a look at sex and gender and how it impacts our lives.
We'll still be counting house races. I can't go.
Yeah.
It's a busy time.
Just as a little bit of an aside, but I do know of one experiment in Africa where they're using drones. I think it might have, is it Rwanda?
It's funded by the Fogarty International Center at NIH. I was going to say to Frida, they're actually using drones to deliver blood products on demand.
Including when a woman is hemorrhaging in pregnancy. That
Which
it's
is
expensive and you don't need to keep it there all the time.
That's right.
But you can get it there really fast by drone.
And there's not refrigeration there, which is a problem with having blood products that can actually support the weight of blood products to deliver them to save a woman's life.
And is that, you mostly work in Latin America, is that, which is not as poor in general, I mean, I know about some of the, I've been to Haiti many times, but generally Africa is more of a impoverished than, I mean, stereotypically is a poorer continent than Latin America. Is this, but they're also remote, poor parts of Andean countries do you know about, is this happening in Latin America too?
Well, I don't know about drones, although I could see where they could definitely be useful in
it's
the
really
Amazon
interesting.
and in places that are very difficult to reach. And certainly maternal mortality is higher in those kinds of places. But we are using kind of more, less, it's not innovative anymore, but sort of telemedicine is being used a lot. For instance, in Bolivia, there's a huge telemedicine network so that people living in rural areas can contact somebody in the city, an expert, and get some kind of feedback on whatever. So definitely that technology is going to contribute, I think, to improving health services for sure.
Oh, can I give one other example, which is one that I love? It's an example in ophthalmology in India, actually, and it's both leadership and empowerment as well as the use of technology to improve health. So if you think about distant villages, the number of ophthalmologists that would be required to just the number of people and the geographic distribution, it would be nigh impossible to ever train enough people to get that work done. And so one of the ophthalmologic families, I guess, leaders in the area, put together a training program, and they trained young women who were unlikely to have education as an option for them as kind of point people, if you would, in the villages. And they have technology that allows them to send pictures back to central reading. They use technology for first strike reading so that they can prioritize for the kind of human reader. They can send different information back and forth, so you're actually getting high-grade care in far-flung places that's being provided at the same time that you're empowering young women to become leaders in their communities. So there are a lot of ways that our various needs for bringing women up financially, through education, in positions of power and respect in their communities, can all happen at the same time that you're trying to uplift the health of the community at the same time. And I just want to add, though, so we all have these individual examples. The question is how we're going to get this at scale. You know, how do we share these amazing opportunities and example, and then how do we make sure that you're not duplicating to solve the same problem someplace, that you are able to tap in? And I think that's another place that technology helps problem solve for us, is connecting us so that we know what's going on and what might be best practices.
Let's take some, we have a mic somewhere? Okay, just grab anybody. Please identify yourself, and please keep it a question, not a speech.
Sorry, Drew Morris from Exelon. I'm curious because, you know, in recent years, we've seen a pretty big groundswell of female empowerment coming from the ground up. You know, the Me Too movement. Susan Kobe obviously did a fantastic job of you know, grabbing the public and actually getting them engaged. How do we leverage things like that to actually get health leaders to actually get people to advocate for their own health requirements, to build that into the healthcare system? Because the groundswell seems to be the way that female empowerment is going. It's not coming from Congress. Hopefully that will change soon, but we want to see that at least start to move, and that can move Congress. So if you can get the people involved, that seems to be the better way to go. So just
In
curious.
some ways, that's a question for Susan McComan, on patient engagement.
I will say we're the great convener, right? And we asked women to do yoga over Mother's Day weekend, and we got 800,000 women to do yoga. You know, I mean, the power of asking. And I think it's really asking the question. We're putting together some cohorts on gathering data, and we have a big data initiative, and it's making sure that we're clear, that people understand what the outcome is. What do we want to have happen, and why are we asking the question? What are we going to do with the information, and how are we going to move it forward? But I think that it really is, when you can ask 800,000, when you ask women in general for Komen, do yoga, and you get 800,000 women, they're willing to participate. We just have to be very clear on what the ask is.
Anyone else want to add?
The other aspect is when women do come and ask a question or say something's not right with my body, if they're not met with a favorable response, you know, there's a disconnect here. So some of the things that we're doing is raising awareness around these gender, sex and gender differences in the healthcare field among all health professionals. So we are developing an online course, actually it's an update of an online course on sex and gender in all different systems of the body, so the clinician will be aware, well, gee, if this woman is saying, I'm short of breath, I had this weird jaw pain, I just don't feel right, I used to be able to walk up 4 flights of stairs and I can't, and they'll say, do you have chest pain? No, I don't have chest pain, but this is not normal for me. You know, those are symptoms that actually may be not enough oxygen getting to a woman's heart, but they have to be met with that. So educating healthcare professionals across the board so that we meet each other halfway.
Because particularly in cardiac emergencies, women present differently, and there's been research.
And just to follow up on that, because I think all of us have been to health conferences that have a focus on women's health, and it's traditionally women who are in the audience. And yet I know half my colleagues are male colleagues and they're taking care of female patients. They need to hear this information. The same for men and women taking care of their family members. We shouldn't be segregating. And I think, as Janine and all of us have talked about, taking that from a sex-gender approach, I think will help to bridge that gap so that everyone understands each other and we become champions for each other. It's not robbing one to feed the other. We realize we're all on the same page and we're coming from that personalized approach and we start to work together.
I also think that I'm not sure that we've told the story in a poignant way. My husband has a saying, people don't change when they see the light, they change when they feel the heat. And so I'm not sure.
I want to go to dinner at your house. It's going to be a lot of fun to listen
Oh,
to.
my house is so much fun. So that's one of my retirement things. So, but I'm not sure that we've told the women's health story in a way that women feel scared about it. Like, I know these statistics and I'm, frightened. And I don't think that if you kind of walked out on the street in front of the hotel and just asked women, do you feel at risk for cardiovascular disease? And do you think that lung cancer is likely to kill you? They don't know. And they certainly don't know the aggregated story of kind of the dangers that are faced by women relative to health. So I think that turning up the heat a little bit by telling the story, not to scare people, but to empower them, to make them think, I need to do something about this right now, for me, but also for my sisters who may not know this yet or may not have access to things. So I think it's a combination of all the things that we do scientifically and a little bit of turning up the heat.
So they can turn the heat up on everybody else.
Exactly, exactly.
As they will.
We have a question here, and then I think you had one after. Okay, this one, and then
Chuck
we'll come over
Stetson,
to these two, please.
I'm a CEO of Stetson Family Office, and we've been working with family offices around the globe. We're in 16 different cities around the globe, but bringing people together in the family office, and we have a particular focus on women and women in healthcare. And so the women in our organization are actually setting up a women in healthcare type of thing for investing, and it relates to leadership and the investment for patient care and all of that. And just a couple of quick comments on research.
Can you please ask the question of the panelists?
I'm framing the question. 5% of the professionals in venture capital are women. It's 25% angels, and we've set a goal of 25% of the women to be decision makers in making investments in healthcare. Will a panel what kind of things can I take back to the women that are in charge of that in our family office in the women in healthcare thing?
Yeah, so you're bringing up a really important issue, and I think a lot of us have worked in various different environments where they've been all-female environments or half and half or all-male. I'm going to take it from predominantly the all-male environment, which has been at NASA, which relates, I think, to what we're seeing in the VC world, and your experiences from the PE world will probably resonate. I think, we talk about women needing to lean in to get the seat at the table. I've known so many women that have leaned in that they're doing front flips to try to get that seat at the table, and it's still really hard. And I think it's too much of a burden on a woman's shoulder to think that you just persevere and you will get it. I really do believe we have to have almost formal sponsorship, championship programs where predominantly it is your male colleagues who've been doing it, where they do champion and it becomes institutionalized. They get rewards for doing it. Otherwise, we're not going to move the needle. I remember Janet Bickle said, and this was 25 years ago, it said at the current rate we're going, it will be 2075 before we'll ever have any kind of equity or parity. So I think we have to have that aggressive push, and we need to have men at the table doing it, working together and championing women so that you get what you're trying to achieve.
We have less than 2 minutes.
I just want to add one thing, which is tell them don't do it by themselves. Like, they don't have to figure it all out, tap into expertise and experience and other people who are doing similar things so they're not starting from the ground up.
Ask for help.
All right. Let's get one of these two, at least at least one of these here. If we get a really quick question, a really quick response, we can get you both in.
Catherine Snedeker from Pink Concussions, Female Brain Injury. I want to thank Janet for sponsoring at NIH last year the Understanding Brain Injury in Women, and that's huge when you have NIH back you. I want to try to reach more women in college before they're mothers, while they're open to so many new ideas, and how have your organizations reached out or have plans to reach out to women in college? Because I think you get 2 for 1 there. You get the woman growing up and then almost before the mother and before she makes decisions in her workplace.
Okay, so just one quick thing. We created the IRS, another acronym, iGiant Roundtable Scholars Program. We have students all across the country and on college campuses creating iGiant Roundtables where they bring together their colleagues, their fellow students, to talk about every issue that we've talked about up here from a sex-gender focus. They're extraordinary, and not only that, they take an active approach. So, for example, one was complaining that their design of their clothing do not have pockets. They can't carry their phones and their equipment. They're actually going to the designers to mandate that there are changes. So we have active programs. Happy to talk to you.
Quick question here, and then we're going to let everybody go.
Shami Fineglass, my question for you on the panel is, there are too few women in leadership roles in academics, industry, a variety of other places. There are a few of us in here involved in Women of Impact. There's some who are Health Innovator Fellows at Aspen. What are other places women can go where they want to be leaders and there's something backing them?
Good one to end up on. A couple of quick responses, and then we'll break up.
So there's an ELAM program that is run out of Drexel, which is for leaders in academic medicine. There are a variety of others in other sectors. What I would love to see is cross-sector collaboration among some of these groups.
So this National Centers of Leadership in Academic Medicine program is still in existence. Many of them are doing wonderful work. One in particular that I really like is the one at University of California, San Diego. Vivian Resnick is the lead on that, and they have helped to promote hundreds and hundreds and hundreds of male and female doctors. And what I've loved about it is that men and women are learning from each other, and they're becoming sensitive to each other's needs. So as they get into leadership, this is not a foreign concept. So you have basically changed the landscape.
Frida, quickly, and then if
one-
there's a global answer to it. You and
Well,
then
I was going to
we'll
do
done,
one
then we're done.
last cross-sector in health, which is a Healthcare Businesswomen's Association, which really has a ground-up approach. Young women who are not yet in but are interested, as well as, the entire spectrum. And it's across, health plans, small companies, large companies, consultants. So it's really the full spectrum of service and work in health to advance women. And there's also been a push to invite men to be more ardent participants in the work, because it's not a woman-for-woman thing. If you're going to get it all the way done, it's going to be all in.
Well, so your question reminded me of some of the impediments to women's leadership that we haven't talked about. And one of the big ones is that women give birth and then they take care of children. And that is clearly related to the fact that they drop off the ladder and then they don't pick it up. They never do. And that's a big problem, and I think we need a groundswell about that. And it's not just women, it's men too. We need maternity and paternity leave, gender equal maternity and paternity leave, that everybody is eligible for. That will bring men into the paid, because we have 6 weeks, I think, right now that's unpaid for women. This is paid. So I think that's critical if women really are going to fully achieve their potential. And I look to the young women in the audience here and to help with that.
All right, we are out of time. This was really an interesting conversation to me. I hope you all got something about it. For those of you who are running labs, go check your rodents.